Welcome to the InnoGuide podcast, where we share the works of authors and mentors to guide innovation. I'm your host, Bob Boudelier. This podcast, my website, my newsletter, and my community are focused on helping you discover the secrets of innovation in the age of AI. Since I don't rely on paid ads, I want to thank our customers who bring me onto their programs on a fractional basis for 10 to 12 weeks as a technical product accelerator, working alongside their teams to help them develop products smarter and faster without adding risk, while bringing human-centered AI skills into their organizations. You can learn more at www.innoguide.net. In this episode, number 92, we'll be sharing Part 2 of Blind Spots by Marty Makary, MD. This is one of those books that was recommended by Peter Attia. I've got to say, it's a book on healthcare that makes your blood boil. In this segment, we'll be covering things like how we wound up with contaminated blood in our blood banks, myths that resulted in more C-sections that still result in more C-sections than are necessary, the true origin of ovarian cancer, and how medical groupthink often presents opinions as facts, and how this has eroded trust in the medical profession. And groupthink, of course, exists in medical product development as well, so this is common in many fields. But you would think that in medicine, where the impact of it is often life-changing or life and death, there would be safeguards in place to make sure that decisions are made on facts and not opinions, and to make sure what's presented to us as the patients is based on facts and not opinions. So this is really a continuation of how the medical establishment actually works or doesn't work, and it illustrates that even when somebody realizes there's something wrong, it may take a generation of doctors to retire before anyone will fix it. So buckle up for another episode, and let's get started. We're picking up around Chapter 6. Bad Blood, How the Medical Establishment Actually Works. This is one of the darkest chapters in modern medical history. This story reveals how institutions prioritize their own survival over patient safety. Kind of a sad story. It's a story about a blood disease and a medical establishment that knew better but looked away. It was 1981. UC San Diego. A young doctor named Don Rucker had just graduated from med school and was working at a clinic. He watched his patients, IV drug users and gay men, many visibly sick with early signs of AIDS, lining up to sell their blood for cash. That's right. Some had open wounds, some had obvious infections, and Rucker, applying basic biology and simple common sense, immediately realized what was happening. Whatever was causing this devastating new disease was traveling through the blood supply. It should have been obvious to everyone, but the medical establishment didn't want to see it. They wanted the blood. So here's where it gets infuriating. Stanford scientists actually developed a screening test within months of Rucker's observations. A brilliant young doctor named Ed Eagleman, just 29 years old, created a simple $10 test that could identify infected blood by looking at white blood cell ratios. When he presented his work to the blood bank officials, this is the Red Cross, they were horrified, not at the threat to patients, but the idea that blood banks would be associated with a deadly disease. His abstract was rejected from their conference. They didn't even show it. They didn't let him present. The establishment had already decided this problem didn't exist, and they weren't going to let evidence get in the way. So what happened? The FDA would not require blood banks to test donations for 7 years. Doctors were crying out about the risks at public forums, but nothing changed. For 9 years, blood banks didn't even ask donors basic questions about their health. Dr. Rucker learned firsthand what happens when you challenge medical dogma. He had a patient with a gastrointestinal bleed, and instead of automatically ordering 2 units of blood, the unquestioned rule, you don't order 1, you order 2. He prescribed iron tablets. The patient recovered perfectly, no transfusion needed. But his senior physicians were furious. They demanded he order blood immediately. They insisted transfusion was mandatory. Patient left the hospital anyway, never needed that blood, and was fine. The blind adherence to tradition had a name. It was called the sacred number. A Hematocrit level of 30%. Two doctors had proposed this threshold back in 1942. There was no scientific evidence behind it. It was simply tradition. By the time I witnessed a senior attending mock a resident for not transfusing a stable patient with a hematocrit of 29, not 30, but 29, this arbitrary rule had calcified into official guidelines. What was the human cost? It was devastating. Patients received unnecessary transfusions, and when doctors gave 2 units instead of 1, they weren't following science. They were honoring tradition. They were also effectively doubling the patient's risk of getting an HIV infection. One meta-analysis found that up to 40% of all transfusions were completely unnecessary. Meanwhile, the American Red Cross, blood bank associations, and even Dr. Anthony Fauci were telling the public that the risk was 1 in a million and extremely small. New York's top health officials actually suggested that hemophilia patients who contracted AIDS had inherent immune defects, essentially blaming the victims rather than acknowledging the contaminated blood supply. By 1985, only 142 Americans had been officially reported with AIDS from transfusions. The Red Cross assured everyone it was completely safe, but they were catastrophically wrong. They were also reaping the benefits of selling all of this blood. When HIV testing finally became available, the actual risk turned out to be 380 times higher than they've claimed. 63% of hemophilia patients became infected. An entire generation died. Conservative estimates put the transfusion-related HIV infections at over 4,600 people, though other reports suggest 29,000 people. And half of those who died did so within 6 months of diagnosis. One journalist called it the hemophilia holocaust. Why did the establishment resist? Because acknowledging the danger threatened the institution of blood banking itself. Medical leaders feared that any admission of risk would discourage donations, so they prioritized the institution over the patients. When have we seen this before? This paternalism has a long history in medicine. Doctors blocking women from home pregnancy tests until 1976 because they wouldn't know how to interpret the results. It's positive or negative, buddy. Preventing HIV self-testing until 2012. Controlling what information patients could access. When testing finally began in July 1985, the medical establishment celebrated prematurely, but the test missed roughly 1 in every 25 infected units, and there was a critical blind spot. It took weeks for antibodies to develop, so infected blood slipped through anyway. An estimated 500 Americans contracted HIV from transfusions even after universal testing began. The FDA's donor screening was equally inadequate. From 1983 to 1990, they didn't even directly ask donors about sexual preference or risky behaviors. When they did distribute a voluntary self-exclusion pamphlet, studies showed 2/3 of high-risk donors ignored it and donated anyway. They were getting paid to donate. Consider Arthur Ashe. The tennis legend underwent heart surgery in 1983, when authorities already knew the blood supply wasn't safe. He received an HIV-contaminated transfusion and died, which was a preventable death, in 1993. Yet the establishment never had an honest conversation about necessity versus risk. This requires something the system resists: medical humility, an admission of uncertainty, a willingness to challenge established dogma. There's a remarkable epilogue here. A hemophiliac named Eric Weiner contracted both HIV and hepatitis C from contaminated blood. Instead of being defeated by the system that failed him, he became a hematologist-oncologist at Yale Cancer Center and eventually president of the American Society of Clinical Oncology. He revolutionized medical culture by championing patient-centered listening and scientific integrity, the very things that were missing in 1981. That's the real lesson. The medical establishment didn't fail because individual doctors were bad people. It failed because institutions prioritized self-protection over truth, because careers depended on consensus, not courage, because speaking up meant professional destruction. The blood supply should have been protected immediately. That's the story we needed to tell ourselves. Instead, we got something far more revealing, a story about how medicine actually works. 7. A warm welcome. Done Dr. Makary shares this story. I'll never forget my first obstetrics rotation as a medical student. I was absolutely terrified of dropping a baby. So terrified, in fact, that I couldn't sleep the night before. When I finally got to cut the umbilical cord, I executed the task flawlessly in 1.5 seconds. But something about it nagged at me. I just severed the baby's blood supply from his mother. And moments later, this newborn was whisked away from his desperately reaching mother to a table under heat lamps. What struck me as particularly unnatural was watching a metal temperature probe inserted into the baby's rectum as part of the standard assessment, all while the baby could have stayed warm and connected to his sweating mother. It seemed fundamentally wrong. This experience introduced him to what he calls the white coat era. For most of human history, mothers naturally held their newborns, maintaining warmth and allowing the umbilical cord to continue delivering oxygenated blood during that crucial breathing transition. Everything changed, though, after World War II, when doctors became an elevated class, armed with antibiotics, advanced surgery, and hospital technology. Medical authority soared, and with it came a profound shift in how we treated the most vulnerable amongst us. But in the 1950s, hospitals separated all healthy newborns from mothers for 7 days. Parents could only glimpse their babies through glass windows. Some were formula-fed under constant fluorescent lights with no sense of day or night. Premature babies faced something far worse. They were routinely strapped down, intubated, and given 100% oxygen. Practices later found to cause blindness and leukemia, despite having no breathing difficulties. Medical schools actually taught that preemies couldn't feel pain, so major surgeries occurred without anesthesia. These babies were paralyzed but awake, able to feel everything. Perhaps most shocking was the dogma of starvation. An influential 1941 textbook by Dr. Julius Hess recommended withholding all food and water from premature babies, instead injecting them with salt water in their thighs. This practice persisted until the late 1960s, when one dissenting pediatrician presented data showing that starvation increased premature baby mortality by 70%. His evidence, of course, was ignored. Dr. Marilee Allen, a Johns Hopkins neonatologist, stood apart from this era. She questioned the conventional wisdom that babies couldn't feel pain, observing their elevated heart rates and desperate attempts to escape during procedures. Her instincts, like mine watching circumcisions performed without anesthesia, told her something was fundamentally wrong. Fast forward to the early 2000s. Dr. Arpitha Chirivolu, a neonatologist, trained in India, arrived in America and was struck by how differently babies were treated on this continent. In India, lack of hospital resources had forced a more natural approach. Mothers held babies skin to skin for at least 6 hours daily. Early breastfeeding and togetherness were standard, but in the U.S., she witnessed rapid cord cutting, heat lamps, formula feeding, and routine separation from mothers. At Baylor University Medical Center in Texas, Dr. Chirivolu became a champion for evidence-based practices that seemed radical to many American doctors. She championed delayed cord clamping, waiting at least a minute before cutting the umbilical cord, because that blood is rich in stem cells, fetal hemoglobin, nutrients, and antibiotics. Her data showed premature babies needed fewer transfusions, less ventilation, and had shorter hospital stays. Today, approximately 90% of U.S. births use this practice. When she became chief of neonatal ICU, she revolutionized care by placing cribs in mothers' rooms rather than separating newborns. Her 2015 policy required 2 to 12 hours of skin-to-skin contact, yielding remarkable results. A 25% increase in breastfeeding, a 50% reduction in NICU admissions, and a 50% reduction in postpartum depression. Skin-to-skin contact normalized babies' heart rates, blood pressure, and blood glucose levels by reducing stress hormones. Dr. Chirivolu also challenged another troubling practice, routine antibiotic overuse. A 2018 JAMA study revealed that 94% of premature infants received antibiotics, yet only 10 to 20% actually need them. Even more disturbing, when test results showed no infection, more than half these babies remained on antibiotics for another week or longer. This damages the microbiome precisely when it's forming. Dr. Chirivolu's hospital now preserves the protective layer of amniotic fluid by delaying newborn bathing for a full week in premature infants. Some hospitals are even studying vaginal fluid swabbing for C-section babies to promote healthy microbiome seeding. The broader issue extends to measuring appropriateness across interventions. While C-sections are medically necessary in only 10 to 15% of pregnancies, according to the World Health Organization, rates reach double that in some U.S. hospitals. Medical schools fail to teach appropriateness of care, creating blind spots where overuse goes undetected. Now that we can measure this data, we face a moral obligation to examine it. Here's what I want you to understand, he says. Modern childbirth care has evolved from one extreme to another, like a pendulum. Decades ago, the 1915 infant mortality rate was devastating. 10% of all newborns in the U.S. died. Hospital practices were an emergency intervention. Through standardized medical care, we've dropped that rate by 93%. That's extraordinary. But pendulums rarely settle in the middle. As we've swung away from past dangers, we've developed new blind spots. We've overcorrected toward over-medicalization. And now thousands of parents reject modern medicine entirely, glamorizing home births. Home births triple the risk of infant mortality. That's not minor. That's a meaningful danger we can't ignore. The real answer isn't swinging the pendulum to either extreme. It's rejecting reactionary thinking entirely. We need to ask, where are we overcorrecting? What blind spots have we created? Modern medicine genuinely saves lives. We have the numbers to prove it, but we also need to reclaim the humane elements of childbirth, the world's most ancient medical procedure. The goal isn't choosing between safety and humanity. It's finding that centered place where we get both. 8. Challenging certainty. Let's start with a story about what happens when medicine gets something fundamentally wrong for 30 years and what it took to finally make it right. Imagine carrying genuine anger towards something for 3 decades. Here's what happened to Dr. B, who developed an almost visceral hatred for ovarian cancer. His mission became singular and unwavering: remove healthy ovaries from post-childbearing women during any surgery. And he wasn't alone. Across the country, countless colleagues shared this practice, and over 7 decades, hundreds of millions of normal ovaries were extracted with the best of intentions to prevent cancer. It seemed like sound medicine. The logic was straightforward. If you remove the ovary, you eliminate the risk of ovarian cancer. The strategy was implemented nationwide, practiced by gynecologists in every hospital and clinic. But here's the thing about certainty in medicine. Sometimes it blinds us to what's actually happening. In 1999, a pathologist named Dr. Louis Dubois asked a question that most colleagues weren't willing to ask. In an essay titled, "Does the Emperor Have No Clothes?" which should tell you something about how brave it took to pose this question, he made a radical observation. Some cells we identified as ovarian cancer didn't actually have the characteristics of ovary cells. It was a heretical thought, but Dubois was onto something. 2 years later, Dutch pathologists examining ovaries removed from high-risk women made a startling discovery. They found precancerous cells, but not where everyone expected, not in the ovaries themselves, but millimeters away, in the fallopian tubes. When pathologist Dr. Christopher Crum at Dana-Farber decided to test this hypothesis extensively, he didn't know he was about to overturn decades of surgical practice. His 2006 study confirmed it. Serious cancer, one of the deadliest forms, actually originates from the fimbriae, those delicate finger-like projections at the end of the fallopian tube. This is where it gets even more striking. His first submission was rejected. The reviewers said it was too far-fetched. Think about that for a moment. A finding that would eventually reshape cancer prevention was initially dismissed as implausible. But the evidence kept mounting. In 2017, Dr. Victor Velculescu and Dr. Ronnie Draper settled the debate definitively. They identified the genetic signature, proving that cells had evolved in the fallopian tubes years before developing into cancer. This wasn't speculation anymore. This was molecular truth. So what does this change? Everything. The old assumption was that postmenopausal ovaries were vestigial, leftover organs serving no purpose. But research revealed something important. They continue producing beneficial hormones. So the solution became elegant in its simplicity. Remove the fallopian tubes while preserving the ovaries during relevant surgeries. A Canadian study of 80,000 women demonstrated the power of this approach. Removing fallopian tubes during hysterectomy achieved a 93% reduction in serious cancer. 93%. To put that in perspective, when we identify a cancer prevention opportunity like that, it typically becomes standard of care immediately. Now consider the scale. In America, approximately 400,000 women undergo hysterectomies annually. Another 700,000 have tubal ligation. Millions more have abdominal surgery in their post-childbearing years. The mathematics are striking. Removing fallopian tubes during hysterectomies alone could save 2,000 lives yearly, while preventing $500 million in cancer care costs. National modeling suggests ovarian cancer rates could drop between 28 and 38% with this single intervention. If we had this kind of prevention opportunity for pancreatic cancer, we would call it the Holy Grail. We would implement it everywhere. Yet, despite these transformative findings and new guidelines from the American College of Obstetricians and Gynecologists, many healthcare professions remain unaware. Canada and Germany have already adopted this standard practice. But the United States has lagged behind. This also reframes how we think about permanent birth control. Historically, we've recommended vasectomy for men and healthy couples seeking sterilization. But if fallopian tube removal reduces cancer risk while vasectomy doesn't, the scales tip toward women having the procedure instead. Though, of course, other factors matter in individual decisions. The bigger question, whether healthy women should have this done as a standalone preventative procedure, remains contested. The medical profession hasn't made a blanket recommendation yet, despite a quarter-century passing since the tubal origin was first identified. The hesitation reveals real concerns. We lack comprehensive population-level data. Our healthcare system couldn't handle the volume, and complication rates vary by surgeon. There are also genuine trade-offs, roughly a 0.01 to 0.001% risk of death or disability from surgery, plus a 1% minor complication risk against a 1.3% lifetime ovarian cancer risk. The evidence suggests that women around age 45 hit the sweet spot. I should address something that matters deeply, too. The terminology opportunistic salpingectomy carries terrible connotations in communities with histories of forced sterilization. During America's eugenics era and in Peru between 1996 and 2000, when 270,000 indigenous women were sterilized without consent, the medical establishment weaponized these procedures. We must rebuild trust through transparency and genuine patient autonomy. We might even rename the cancer itself, calling most cases fallopian tube cancer rather than ovarian cancer. It would be simply more accurate. This chapter was simply about intellectual courage. It's about the humility to challenge long-standing assumptions, even those held with absolute conviction. 30 years of removing healthy ovaries would have continued indefinitely without doctors willing to ask difficult questions. Today we have a more precise way to fight ovarian cancer. We don't have to routinely remove healthy organs anymore. That's the power of challenging certainty. 9. Silicon Valley. There's a moment in every regulatory story when you have to stop and ask yourself, what are we actually protecting people from, and what are we overlooking? That's exactly what happened in the 1990s with silicone breast implants. And the answer to that question reveals something troubling about how our government makes decisions about medical safety. Dr. Makary says this, "Let me start with something I observed firsthand. I had a former resident named Joe, talented surgeon, real promise in cancer research. But, like many of his peers, Joe eventually left that path to perform cosmetic procedures in what we call Silicon Valley and the Silicon Coast. And this wasn't unusual. Over 30 years, more than 1 million American women choose silicone implants, some for breast cancer reconstruction, but others seeking to boost their confidence. It was a thriving part of medicine, and surgeons like Joe were drawn to it. Then came December 10, 1990. Connie Chung broadcast a segment on breast implant illness to 13 million viewers. She presented several women claiming that silicone implants had caused their health problems, chronic pain, fatigue, joint issues. The segment was one-sided, presenting cases without scientific backing. CBS even canceled the response ad from the implant manufacturer without explanation. It was media sensationalism at its finest, and it lit a match that would burn for years. Congress held hearings where only plaintiff-paid expert witnesses testified. One congressman claimed that cancer risks were 100 times higher than reported. Within 13 months, FDA Commissioner Dr. David Kessler announced a ban on silicone implants. His reasoning? Unknown leakage rates, potential cancer risks, possible autoimmune disease connections. Concerns based largely, and I want you to understand this, on a report involving just 3 women. What happened next was remarkable. The publicity didn't just inform the public, it created the disease. Dr. Doug Wagner, a plastic surgeon who lived through it, explained how this worked. Women began developing what became known as breast implant illness, poorly defined syndrome with vague symptoms like fatigue and brain fog. The power of suggestion was extraordinary. Women started attributing normal aging changes to this novel disease. Never mind that in any group of 1 million women, 40 to 50,000 naturally develop connective tissue diseases regardless of implants. Now, those with implants blame their devices. Some physicians pushed back hard. Dr. Marcia Angel, who would later become editor of the New England Journal of Medicine, criticized Kessler's impossibly high standard. She noted that implants had 30 years of safe use behind them. Plastic surgeons pointed out that the existing data supported safety and accused Kessler of bias against cosmetic procedures. They had a point. But here's where the story gets truly striking. While Dr. Kessler obsessed over silicone implants lacking long-term studies, his own FDA was simultaneously approving something far more dangerous. In December 1995, the agency approved OxyContin, a highly addictive opioid based solely on a 14-day clinical trial and a company's unsubstantiated claim that its controlled-release formula would reduce abuse potential. The agency demanded nothing comparable from opioid manufacturers compared to what it demanded of implant makers. Dr. Janet Woodcock oversaw the division that granted this approval. She allowed Purdue Pharma to abandon its promise to conduct additional studies, a pattern that would continue for 23 years. No valid evidence existed that OxyContin safely treated chronic pain, yet the FDA's approval label gave Purdue's sales representatives the ammunition they needed to convince skeptical physicians. The irony is almost surreal. While the medical community scrutinized silicone breast implants under a microscope, it embraced opioids with dangerous enthusiasm. Consider this. Women receiving implant-related surgeries were prescribed excess opioid doses based on a 1980 letter claiming addiction was rare. Some of these women may have died from these medications rather than from anything related to their implants. The litigation that followed the implant scare essentially birthed American mass medical tort. Trial lawyers seized on public anxiety, affirming women's belief that implants caused their ailments. Within 2 years of Kessler's ban, juries awarded millions to women in individual cases, and by 1995, 440,000 women registered in a settlement. Dow Corning ultimately paid $3.2 billion, the largest medical injury settlement at that time. Trial lawyers Stanley Chesley and John O'Quinn built legal empires from this litigation. Later, they faced their own reckoning. Chesley was disbarred for cheating clients. O'Quinn was ordered to repay $41 million in overcharged fees. But here's what happened to the science. The Mayo Clinic, the American College of Rheumatology, and the American College of Neurology, they all examined the evidence and reached the same conclusion: no association between implants and autoimmune or connective tissue diseases. Cancer risk appeared unaffected or possibly even reduced. By 1999, the Institute of Medicine issued a definitive report concluding that implants cause no systemic disease. Even Kessler himself admitted in 1998 that he'd found no evidence of systemic disease. In 2006, after the 14-year ban had run its course, the FDA quietly lifted it. Today, silicone remains the implant of choice, and the fears have largely been forgotten. Meanwhile, the opioid epidemic, enabled by that same FDA's negligence, has killed over 1 million Americans. The contrasts couldn't be starker. Dr. Kessler advanced to prestigious positions at Yale and UCSF, and later served as Biden's COVID science advisor. Dr. Janet Woodcock, despite orchestrating what many consider one of the worst regulatory failures, became FDA acting commissioner in 2021. That prompted protests from 28 public health organizations. This is what happened when we let fear, not evidence, drive medical policy, and when we ignored the real crisis unfolding right before us. 10. Comedy of Errors. In this chapter, he talks about one of the more troubling patterns he encountered, one that haunted him during his training and continues to disturb him today. The remarkable confidence with which we embrace ideas that turn out to be spectacularly, catastrophically wrong. He remembers memorizing surgical procedures in med school that make him wince now. He says, "We learned to cut the vagus nerve, to reroute intestines, all to treat stomach ulcers. Barbaric interventions based on a single unquestioned assumption that stress caused them. But when you step back and think about it, the honest answer should have simply been, we don't know what causes them." But that's not what we said. We acted with absolute certainty. This pattern of medical groupthink is what I want to explore with you today, he says, because it appears again and again throughout history, from medieval times straight through to the modern era. And the most perfect illustration of this phenomena is the story of Dr. Barry Marshall. In the early 1980s, Marshall challenged everything we thought we knew about ulcers by resurrecting a 100-year-old hypothesis that bacteria caused them. And to prove his point, he did something extraordinary. He drank the bacteria himself. He infected his own body, got sick, and then cured himself with antibiotics. You'd think the medical world would have celebrated this. Instead, when Marshall and his colleague, Dr. Robin Warren, submitted their groundbreaking findings to a medical conference in 1983, they were rejected outright. Didn't even crack the top 56 accepted abstracts. It wasn't until the early 1990s, a decade later, that the medical establishment finally accepted what the data had been showing all along. Marshall and Warren eventually won the Nobel Prize. But imagine the human cost during those lost years. Think about how many unnecessary surgeries were performed. How many people suffered needlessly because we were too attached to our old ideas to listen to new evidence. This resistance to innovation runs deep through medical history, and I found myself captivated by the stories. Take Dr. Michael Servetus in the 16th century. He accurately described blood circulation, not in a medical journal, but buried in a theological treatise. His mistake? He contradicted the prevailing belief that blood simply sat stagnant in the body. For this heresy, along with his theological criticisms, John Calvin had him burned at the stake. Think about that for the moment. But 25 years later, Dr. William Harvey was born. Harvey took Servetus's theory seriously and did something radical. He conducted meticulous autopsies to test it. He performed mathematical calculations proving that the heart pumped blood in a circular pattern throughout the body. When he published his findings, physicians called him crack-brained. His medical practice suffered tremendously. Yet, historians now recognize William Harvey's discovery as the greatest breakthrough in the entire history of medicine. Or consider Dr. James Lind, who in 1747 conducted what might be history's first rigorous, controlled clinical trial. Aboard the HMS Salisbury, of all places, he tested 6 different remedies for scurvy on pairs of sailors. Scurvy was a monster. It killed approximately 2 million sailors between 1492 and the 1800s. 2 million people. And Lind discovered that oranges and lemons cured it, yet his findings were largely ignored for over 40 years. The Royal Navy didn't begin stocking lemon juice until decades after his publication in 1753. Even Dr. Edward Jenner's vaccination breakthrough faced fierce resistance. Farmers had observed something simple but profound. Milkmaids infected with mild cowpox didn't contract deadly smallpox. This was obvious, observable knowledge from people working the land, but elite physicians mocked it as countryside folklore. Jenner alone took their wisdom seriously enough to investigate further. After 20 years of research, Jenner developed the world's first vaccine. He deliberately infected an 8-year-old boy with cowpox material from an infected milkmaid, then later exposed him to the full disease to prove immunity worked. His discovery promised to eradicate smallpox, one of history's worst pandemics. Yet when he presented his findings to the Royal Society, an institution supposedly devoted to objective science, They warned him not to publicize such a wild idea. Undeterred, Jenner published anyway and traveled to London to conduct larger trials. He struggled to find volunteers at first, but the breakthrough came when influential physicians like Benjamin Waterhouse and Thomas Jefferson endorsed his work. Jefferson established the National Vaccine Institute. By 1980, the World Health Organization declared smallpox eradicated. Millions of lives saved because one man had the humility to listen to farmers. Then there's the heartbreaking story of Dr. Ignaz Semmelweis. In 1846, he noticed something peculiar in Vienna. One obstetrical clinic had a maternity mortality rate of 10% from childbed fever, while another had less than 4%. When his friend died from an autopsy wound infected with the same pathogen killing pregnant women, Semmelweis connected the dots. Doctors weren't washing their hands between examining cadavers and patients. He implemented a hand-washing protocol with chlorinated lime. Deaths dropped by 90%. 90%! His gentlemanly colleagues were insulted at the suggestion that they had dirty hands. Even when his protocol produced remarkable results in Budapest, medical elites attacked his published work. Semmelweis descended into depression and was admitted to a mental institution where he died, possibly from a beating by a guard that infected his hand. Finally, Dr. Caitlin Carrico developed mRNA vaccine technology years before COVID appeared. Penn University fired her, demoted her 4 times, cut her pay, denied her lab supplies, and refused to fund her research. She couldn't publish or secure grants because the idea seemed too radical. Only through supporters like Dr. David Langer and Dr. Drew Weissman did her work continue. When she and Weissman won the 2023 Nobel Prize, Penn suddenly celebrated her as brilliant, the same institution that had marginalized her. These stories reveal something fundamental about human nature. Those in power protect their established ideas. Innovation threatens the mental peace of entrenched beliefs. Leaders without humility actively resist progress. Yet these innovators persisted despite being attacked, canceled, and defunded. They changed the world. That's what inspires me, and it should inspire anyone attempting positive change. 11. A culture of obedience. We live in a culture increasingly pressured to conform to conventional thinking, and this conformity is quietly killing scientific progress and medical advancement. The doctor experienced this firsthand when filling out paperwork for a Johns Hopkins lecture. A standard form asked whether his recommendations would be based on evidence that is accepted within the profession of medicine as adequate justification. He answered honestly, no. He says this about his research. My research challenges medical assumptions using the scientific method, developing hypotheses, testing them, and interpreting the findings with an open mind. That honest answer generated confusion and concern, though I ultimately gave what my hosts called their best grand round speech ever. It illustrated how often we're nudged to simply go along. The pressure to conform happens at every level of medicine, happens at every level of business too. NIH grant applications are reviewed by senior scientists who tend to favor proposals supporting their established ideas. This is precisely why cancer research, chronic disease research, and biomedicine have stagnated for decades. Despite $8 billion in annual taxpayer spending on cancer research alone, the results are meager. The top breakthroughs presented at major cancer conferences showed a chemotherapy drug extending survival by just months for incurable brain cancer, curing no one. Medical journals and societies wield similar gatekeeping power. Editors and editorial boards, often composed of like-minded colleagues serving lifetime positions, control what the broader medical community reads. This entrenchment explains why we see less groundbreaking innovation and more incremental, safe research. The situation became alarming in 2023 when major medical societies filed an amicus brief supporting government censorship of medical speech. They argued the government has a compelling interest in combating health misinformation. This precedent is dangerous. A doctor recommending against a mammogram for low-risk 40-year-old women could theoretically face censorship. California attempted this through a 2022 law allowing physicians to lose their licenses for disagreeing with the state health board recommendations. The law was repealed after an outcry from UC San Francisco and Stanford scientists, yet the incident raises troubling questions. What if those recommendations were based on fraudulent research? In 2024, Harvard's Dana-Farber Cancer Institute retracted 6 articles and corrected 31 others due to manipulated data. Over 10,000 medical journals were retracted in 2023 alone, a record. Silencing doctors who disagree removes crucial checks on scientific integrity. He says this, "Let me paint you a picture of what's happening in our medical institutions today, and it's deeply troubling. When Dr. Leana Wen, former Baltimore Health Commissioner and Planned Parenthood CEO, dared to suggest that people should assess their own COVID risks, over 600 public health academics signed a letter demanding her removal from a conference panel on bullying. The irony is stunning. She wasn't accused of manipulating data or falsifying research. Her crime was thinking differently. She was bullied out of the conference by the very experts claiming to fight bullying. When I tried attending that same conference, I discovered it required 3 COVID vaccine doses, despite my natural immunity from a previous infection, which my research team documented. That study, which showed robust antibiotic responses in recovered patients, was censored on social media, yet eventually became JAMA's 3rd most discussed article of 2022. What disturbs him most is this doesn't break along partisan lines. Dr. Wen is a Democrat, yet the academic public health community excommunicated her. Universities claim to champion inclusion and diversity, not just ideological diversity. Consider the American Board of Internal Medicine, a private monopoly now threatening to revoke board certification from doctors who express opinions disagreeing with their leadership on medical controversies. At elite universities, Harvard, Stanford, MIT, Johns Hopkins, there were 0 debates during COVID about school closures, hospital visitation bans, or mask mandates for toddlers. The first MIT debate on COVID vaccine boosters happened in February 2024 after the pandemic ended. Students and faculty came away hungry for civil discourse. The contrast with the Royal Society in London is striking. Their motto, nullis in verbra, take nobody's word for it, enshrines their commitment to withstanding authority and verifying claims through evidence. The doctor says this, "Throughout my career, I pursued medicine's blind spots, topics our profession avoided discussing but desperately needed to address. These gaps don't exist because medical professionals are malicious. We're good people, trapped in a flawed system. Yet colleagues told me my work would never succeed, and yet nearly every project ultimately transformed medical practice. When I challenged hospitals investing in tobacco companies, I was assured divestment would never happen. Yet within 20 years, most major institutions divested. As a resident, I witnessed an epidemic nobody discussed, preventable medical errors. I studied non-technical skills like teamwork and communications, and working with Dr. Peter Pronovost, I developed a surgical checklist based on cockpit protocols. Colleagues dismissed it as Mickey Mouse Club, yet our research proved it improved outcomes. Today, the World Health Organization's surgery checklist is standard worldwide and has saved more lives than major chemotherapy advances in the first year alone. This pattern repeats across multiple initiatives. When he called for hospitals to publicly report medical errors and quality metrics, he was told it was impossible. But within years, Medicare mandated this transparency. His research on frailty as a surgeon outcome predictor was also deemed soft science, yet it became recognized as crucial to surgical decision-making. We're spending $4.5 trillion annually on healthcare. Yes, that's right, trillion. Yet our current system doesn't deliver results. Most American adults take 4 or more prescription medications regularly, making us the most medicated population on the planet. We're in what he calls an intellectual civil war about the very foundation of modern medicine itself. The question is this: should the scientific method guide our inquiry, or should consensus opinion reign supreme? Here's what he believes: open debate and rigorous discussion of data over dogma create a stronger society. They foster civility. They accelerate medical discovery. When we're willing to challenge consensus respectfully, when we prioritize evidence over groupthink, when we protect the freedom to ask the difficult questions, that's when real progress happens. We can't build a healthier future on a foundation of intellectual conformity. We need room to think differently, to question, and to discover. That's not rebellion. That's essential innovation. 12. What else are we getting wrong? Dr. Makary asks a great question here. If we got so many major health recommendations catastrophically wrong over the past few decades, we have to ask ourselves an unsettling question. What are we getting wrong right now? The answer is probably more than we'd like to admit. Here's what troubles him most, and me as well. Medical dogma is actually stronger today than it used to be. We're less tolerant of different opinions, and medical authority is more centralized than ever. A landmark study found that 40% of accepted medical practices don't hold up under rigorous testing. 40%. That's staggering. Consider Bob Marley's case. His doctors dismissed a discoloration on his foot as a sports injury because conventional thinking said, black people don't get melanoma. That wasn't wisdom, that was medical dogma. And it killed him at 36. The real problem is that we use clinical wisdom to plug gaps where research hasn't caught up. And that's sometimes necessary. But then we present opinions as scientific evidence. A former JAMA editor told him that 60% of what physicians do lacks good scientific backing. Why? Because research funding follows the money. And the money is in pharmaceuticals. Studies on food, lifestyle, and nutrition almost never get funded. So we pour billions into new drugs while barely studying how food affects inflammation or the microbiome. Given how many major health recommendations we've already reversed once properly tested, imagine how many current recommendations might need reversing if we actually studied them rigorously. Without good evidence, current viewpoints are opinions. Let's stay open-minded. Now, he's going to walk us through some serious concerns he has about how we're approaching cancer screening. Take the Galleri blood test, which detects early cancers. Sounds great, right? But here's what the data actually shows. 58% of people, more than half, the test says might have cancer, don't have it at all. Let's say that again. 58% of the people the test says might have cancer, don't have cancer. Meanwhile, it misses up to 70% of actual cancers. Many detected cancers were already in late stages or slow-growing turtles people could outlive anyway. Those false positives, 58%, send people down rabbit holes of invasive follow-up testing. Patients spend an average of 162 days waiting for results. That's 4.5 months of genuine psychological and physiological stress. What concerns him most is the corporate angle. The company's executives suddenly resigned in 2023 and dumped their stock. Now there's a massive $60 billion lobby pushing to get Medicare to cover the test for every older American. I believe in early detection's promise, but we need actual evidence that this saves more lives than it destroys before we spend that kind of taxpayer money. Let's walk through 3 other areas where we're getting medicine wrong, and they reveal a troubling pattern. First, testosterone replacement therapy can improve bone density and help with type 2 diabetes, but it has real downsides. Extended use can permanently shut down your body's natural testosterone production, creating dependency. When men stop, they lose all benefits immediately. Many men who genuinely benefit from TRT aren't being offered it, suggesting modern medicine may be underappreciating this therapy. And while he doesn't discuss it here, in one of the other books, they talked about how women lose all their testosterone when they go through menopause. And many women benefit immensely from testosterone replacement therapy, yet few of their doctors ever test it, and they aren't inclined to offer any kind of HRT. The second one is gender-affirming care for children. The U.S. Assistant Secretary for Health called this suicide prevention care, yet no definitive study shows that surgery or puberty blockers actually reduce suicide risk. That's an opinion, not evidence. The UK commissioned a formal review and concluded that puberty blockers lack good evidence and haven't proven safe or effective. Their research showed 71% of children on puberty blockers had no mental health improvement, with 1/3 getting worse. Sweden and Denmark have similarly restricted these treatments. In America, we're not debating. Researchers who published findings challenging this narrative faced institutional retaliation. A journal forced one researcher to change her article title after publication. The third one is tongue-tie cutting. Dentists and pediatricians are slicing babies' tongues based on dubious claims about breastfeeding and sleep apnea. Yet a major systemic review found no positive breastfeeding benefits. We're cutting millions of children's mouths without proper clinical trials. These cases share something crucial: major clinical questions living in funding vacuum, backfilled with opinions rather than evidence. The AAP's 15-year error on peanut allergies teaches us something vital. When there's uncertainty about a practice, we need proper studies before it becomes widespread. Yet, we keep repeating this mistake. Take GLP-1 drugs like Ozempic. They're celebrated for weight loss in short-term studies. But what we don't know is their long-term side effects. These medications reduce both fat and muscle mass is the leading predictor of longevity. We're genuinely uncertain whether long-term use extends or shortens lives. Then there's the recent mammogram recommendation, lowering the screening age for low-risk women from 50 to 40. You'd think this would be backed by clinical trials proving it saves lives, right? It isn't. There's not a single trial demonstrating that mammograms in low-risk women in their 40s actually saves lives. Yet the recommendation was issued anyway, based on opinion rather than evidence. Looking back through medical history, he notices a troubling pattern. Over just 1 decade, researchers identified 146 contradicted medical practices. Treatments we were absolutely convinced worked until we discovered they didn't. We automatically gave fever-reducing medication without questioning whether that was actually helpful. Fever itself is a protective mechanism. We were interfering with our body's natural defenses. So where else are we getting things wrong today? What current medical practices will we look back on in 20 years with embarrassment and regret? The hardest part isn't discovering these errors, it's admitting them while you're still defending them, still staking your reputation on them. David Sackett, the father of evidence-based medicine, warned that preventive medicine had become arrogant and presumptuous. He emphasized that good medicine requires both clinical expertise and best available evidence. Neither alone suffices. We must hold science to high standards, acknowledge our biases, and maintain intellectual humility. Sometimes the right answer is simply, I don't know. So that's the end of Blind Spots, When Medicine Gets It Wrong and What It Means for Our Health by Marty Makary, MD. Again, I can't help but marvel at the similarities between medicine and technology with respect to how people with more range and the ability to see across disciplines, not just within the depth of their discipline, these people always have an inquiring mind and an advantage at discovering more generalized problems, and they leverage that knowledge in finding solutions. And of course, the problem of cognitive dissonance mentioned in Part 1 is seen all over in medicine, social media, and technology too, as a result of us curating our own information, including our news, and spending most of our time in our own echo chambers. As I stated at the end of Part 1, it's just unfortunate that the health organizations that are expected to protect our health have no safeguards to prevent dogma from driving decisions instead of science driving them. Enough about that. As you can probably tell, I really enjoyed the book, Blind Spots, When Medicine Gets It Wrong and What It Means for Our Health by Marty Makary, MD. Think you'll enjoy the book. It has many more examples and a lot more depth than what I've covered here. And if it doesn't make your blood boil, well, then you're a better person than I am. Remember that our website is www.innoguide.net, where we have many resources for innovators, including those who want to leverage system-level thinking to get runaway timelines under control in the medical product development process, and those who want to leverage AI in their development process without adding risk, and of course, to help those who want to build medical products that will support embedded machine learning now or in the future. Just know you'll be learning it from someone who's worked in medtech for 30-plus years and has led teams who developed and delivered 66 medical products. I've also recently launched MedX, our medical executive discussion forum, where leaders gather once a month for an hour to share insights about how to navigate medtech product development in the age of AI. You can join using the MedX forum button on my LinkedIn page. Last but not least, I want to thank Steve McIntyre for producing this, and I really want to thank you for joining us. I look forward to seeing you next time. That's a wrap.